We might make a start, as we have lots to listen to this afternoon. I have the pleasure of chairing this first session of the afternoon, and I am doing so in the context of bringing different diverse experience or background. So I sit on the NHMRC Healthcare Committee, and I have for the last triennium and indeed for the upcoming triennium, and it sounds like Warwick has a lot more work in store for us this time around. I've also worked with not-for-profit organisations, several of them. I am very deeply embedded in the healthcare sector, and I hold an NHMRC practitioner fellowship. And probably the most challenging part of what I do has been around engaging with government. But probably what drives me in the workplace more than anything is that I'm very passionate about implementing evidence into practice to deliver health impact. And ideally all of us would be in a similar situation given that we're in health and medical research. But there are, as we've heard this morning, many barriers to that implementation. And in meeting with Jonathan Lomas, who was seconded out to the NHMRC more recently, some of the key messages that he was talking about are the critical need to engage end users throughout the whole cycle of research, even where we're conceptualising at the discovery research level or at the clinical or public health level, to ensure we engage end users and stakeholders in our entire research process to make sure what we actually generate can be implemented. I'm also a very strong supporter of the concept of faculty translation, and I'm sure whilst there will be learnings along the way, that ultimately it will be for the betterment of health and medical research in this country. We've got an illustrious group of people who are going to give some really fantastic exemplars of implementation and translation. We've got a physiotherapist, a public health surgeon, there's a challenge for you, an OC health and safety physician, and also a pharmacist from a clinical perspective, who are all going to give you quite different. Sally Green is going to talk about the framework of knowledge translation, and the others are going to give you some successful exemplars of implementation and translation, and hopefully tell you about some of their challenges as well as some of their wins. So first of all, I'd like to introduce Professor Sally Green. Sally is the co-director of the Australasian Cochrane Centre. She's also a professor or fellow in the Faculty of Medicine at Monash University. She is a physio-clinically by background and holds a PhD in epidemiology and has numerous implementation grants, and Sally's going to set the scene for us about knowledge translation exchange. Thank you, Sally.
Thanks, Helena. Don't clap me yet. I'll wait till the end. I'd like to start by thanking Davina Guernsey and the team at the NHMRC for the opportunity to present some of the thinking and work we've been doing within the Cochrane entities in Australasia, particularly around translating the results of Cochrane reviews into practice and policy. I'm a new glasses wearer, so please forgive me. My eyes are deteriorating. See how we go. I haven't given a presentation with glasses on before. Okay, my declaration of interest. I'm co-director of the Australasian Cochrane Centre, as Helena said, and therefore I'm passionate about the production and use of systematic reviews. I'm an investigator on research projects investigating effective research translation and implementation strategies. As Helena said, I'm a physiotherapist currently practising 1 day a week, and my biggest bias, I'm a lifelong and somewhat tragic St Kilda supporter. What I'm hoping to cover this afternoon is to briefly articulate the problem of the gap between research and practice, to frame my talk by ensuring that we have a shared understanding of what I mean by some of the key definitions and concepts of research translation, sorry Warwick, and to give some examples of how the Cochrane collaboration within Australasia has gone about trying to build a culture for evidence use. In 2006, the World Health Association, through its then director Lee, stated that there is a gap between today's scientific advances and their application, between what we know and what is actually being done. Health work teaches us with great rigour that action without knowledge is wasted effort, just as knowledge without action is wasted resource. This articulates the two key concepts of why we need research translation: to guide better healthcare and to make the best use of research. The WHO view this endeavour as one of the most important challenges for public health this century. To my mind, one of the best articulations of the difficulties of getting research into routine care comes from an article in the Washington Post by Stephen Wolfe, a GP. This article, titled "All Breakthrough, No Follow-Through," he points out that in the United States, for every dollar allocated by Congress to develop breakthrough medical treatments, only 1 cent is allocated to ensuring that the patients actually receive them. This idea has caught the attention of some pretty high-power speakers. In his address to the American Medical Association in 2009, President Obama pointed out that one thing we need to do is figure out what works and encourage rapid implementation of what works into your practices. Australia is not immune to this so-called no-do gap. Earlier this year, the Medical Journal of Australia published the Care Track study, which many of you may have seen. This study demonstrates with contemporary Australian data that the gap between research and practice is as relevant to Australian healthcare as it is in other countries. The Care Track study interviewed and conducted retrospective review of the medical records of over 1,000 patients seeking care in a range of healthcare settings. This table shows the percentage of encounters by condition at which appropriate care, as defined by compliance with evidence-based and consensus indicators, was delivered. There are some excellent examples, such as 90% compliance for coronary artery disease, but on average, across the 522 indicators in more than 35,000 encounters, there was a 57% compliance rate with the indicators of appropriate care. Now, of course, there are a range of complex factors explaining and potentially confounding these findings, and many of the indicators are not based on research, and the population of the patients and practitioners may not be representative. But nonetheless, these findings do underline the importance of ensuring that research-based evidence is available and is implemented into practice. Larry covered this morning many of the key concepts and definitions of knowledge translation, but I think it would be helpful to briefly revisit those that we have used in developing our approach to ensure a shared understanding. We see two distinct but interrelated aims. First, ensuring that stakeholders are aware of and use research evidence to inform their health and their healthcare decision-making. And second, ensuring that research is informed by the research that has gone before it and by the experiences and the information needs of stakeholders. We identify healthcare professionals or practitioners or clinicians, consumers, patients and their families and carers, educators and policymakers and research funders as the key stakeholders for research use. You've already seen this version of this figure this morning, this model of translation. This one's from the Institute of Medicine Roundtable, but it's very similar to the one that Larry showed. I'm putting it up again, not to go through it again, but really just to point out, as Larry said, that our work within Cochrane is most applicable to furthering our understanding of T2, not of T1, although I do hope that some of the following examples will be relevant to research translation in general. Over the past few years, we have been trying to come up with the best way to explain the approach that we at the Australasian Cochrane Centre, in collaboration with many of our colleagues here in Canada and in the UK, are taking to research translation. We wanted to demonstrate research translation as a practice in translating the results of Cochrane reviews and as research in developing and testing various strategies to implement research into practice. While we recognise that there are many different models of research translation, we wanted something that would illustrate our method, reflect the iterative and non-linear processes, and also provide some structure. The answer came to us in the form of a very helpful piece of grant peer review. The reviewer was anonymous, so we can't acknowledge them, but in their review of the NET program, which is a program of research translation that Russ Gruen's going to speak about a little later, the method that we outlined in our proposal was described as trying to deconstruct a rainbow. So, the research translation rainbow. The inner band, or foundation, is identifying the important research questions. The generating and synthesising of knowledge to address these important questions comes after. People making healthcare decisions, the stakeholders for research translation, need to have access to this synthesised knowledge. We need to identify where current practice and policy is divergent from research. In addition to identifying the gaps, we need to understand them, including the determinants or barriers and enablers to practice and policy change. Based on our understanding of the gap, the next band involves developing interventions to facilitate change. These interventions may be best if underpinned by theory and should draw on the evidence for various implementation strategies. Once we have established that this is likely to work, we need strategies to sustain these changes in practice and policy. And, overarching it all, we need an infrastructure for research translation and a culture of evidence use to enable research translation. So, what are some examples of the ways we have approached creating a culture for evidence use within the framework of our rainbow? Research will not be used if it is not addressing questions of importance to those who use research. Recognising this, in a correspondence to The Lancet, Alessandro Liberati, past director of the Italian Cochrane Centre, who sadly died from multiple myeloma in January this year, states, "I have had the opportunity to consider, from more than one perspective, the mismatch between what clinical researchers do and what patients need." He calls for a forum of communication between patients, researchers and research funders to ensure the questions of importance are addressed. Another approach to building a culture of addressing important research questions is the use of research syntheses, which include a systematic search and identify a lack of evidence or identify emergent research. The Australasian Cochrane Centre is working to facilitate this through CRISP, or Cochrane Reviews Identified and Summarised for Policy. CRISP summaries primarily aim to summarise Cochrane reviews to inform health policy decisions, but they also include identification of where we do not know the answer. For example, in this review conducted in Australia, there is insufficient but emergent evidence for Indigenous healthcare worker involvement for Indigenous adults and children with asthma. Here we can see that there is only one small but recent study, so we do not yet know the answer to this research question. While most of us will be used to thinking about the dissemination and translation of the results of our own projects, so-called end-of-grant translation activities, including publication, presentation and the dissemination of key messages to relevant target audiences, there are strong arguments that the results of individual studies need to be interpreted within the context of global evidence before embarking on widespread research translation activities. In their paper, Knowledge Translation of Research Findings, published in Implementation Science, Jeremy Grimshaw and colleagues proposed that the basic unit of knowledge should be up-to-date research synthesis. In practical terms, researchers faced with translating the results of their own studies should consider how these fit with other studies addressing the same or similar questions, and ensure the key messages to be translated are based on a body of evidence, ideally a systematic review or evidence-based clinical practice guideline. For widespread practice and policy change, individual studies rarely provide sufficient evidence. A strong case for the translation of research within the context of bodies of evidence is made in a series of landmark papers by John Ioannidis and colleagues, in which they explored the evolution of evidence in healthcare over time and observed, for both clinical and basic sciences, that the first published study on a specific topic was likely to have the biggest effect and that this would stabilise and lessen over time. To demonstrate this with respect to clinical studies, they analysed 115 articles published between 1990 and 2003 in the three major general medical journals, that is the New England Journal, JAMA and The Lancet, and in specialty journals that had received over 1,000 citations each by August 2004. Of these 115 studies, 49 reported evaluations of healthcare interventions and 45 claimed that the interventions were effective, a good example of what Larry was discussing this morning. By 2004, 5 out of the 6 of the non-randomised studies and 9 out of 39 randomised trials were already contradicted or the effect size lessened with repeated studies. They demonstrated the same concept for genetic research. This figure shows 8 disease gene odds ratio associations, demonstrating in all cases that as more evidence was accumulated over time, the size of the odds ratio stabilised but reduced. Perhaps the most obvious need to bring about a culture of evidence use is that healthcare decision makers can access research. But access is not just about finding research, and research needs to be understandable, relevant, and appropriate for use by different research users, in particular clinicians, consumers, and health policymakers. The NHMRC recently renewed a national licence to the Cochrane Library, enabling all Australians with access to a computer free access for the next 5 years. Australia launched its first national licence in 2002, hence we have had 10 years of nationwide access to Cochrane systematic reviews. Australians also have ready access to clinical practice guidelines through the NHMRC's guideline portal. However, access to research extends beyond being able to find it. There may be other access-related barriers, such as how understandable the information is, the appropriateness and relevance of the research to a particular setting, and importantly, time. In an example of getting the questions right, translating research synthesis, I'm having trouble with that today, and improving access, and making sense of MS. The Making Sense of MS research website is a great example of research translation for consumers. Developed as a model of partnership between the Cochrane groups in Australia and Italy, the MS research community, an NGO at national and state levels, health professionals and many consumers and carers in advisory and research participation roles, this site summarises Cochrane reviews for people with MS and their families and their carers. In addition to a consumer-friendly summary of the review itself, the site includes advice on whether the evidence applies to particular patients, suggestions of questions to ask health professionals, and more detailed information. A second example of research translation for consumers comes from the Cochrane Musculoskeletal Group, led in Australia by Rochelle Bookbinder, who's speaking a little later this afternoon. In partnership with Arthritis Victoria, they have used Cochrane reviews to inform decisions for people with arthritis. A novel method of research translation for clinicians, the Cochrane Journal Club provides a clinical summary of a Cochrane review, along with a presentation and series of questions and answers which can be used as a journal club. This one, based on the review of interventions for preventing obesity in children, comes from the Cochrane Public Health Group here in Melbourne. And also targeting clinicians, this time through the Medical Journal of Australia, recent relevant reviews are summarised in order to help overcome time and access barriers. Even with increased access to reliable research, in many cases, practice will not change. Routinely conducted practice audits and registers can facilitate identifying areas where change interventions beyond research access may be needed. However, the evidence base for selecting interventions for any given implementation problem is incomplete. Using theory or theoretical frameworks like the theoretical domains framework pictured here may help to understand the pathway of behaviour change required for an implementation intervention to work in a given context. Theory can be used to assess the determinants of research uptake using qualitative or quantitative methods. Dutch researcher Richard Grohl said evidence-based medicine should be accompanied by evidence-based implementation. In selecting interventions to change practice and policy in response to research, we need to know which strategies to facilitate the uptake of research into practice are effective. The Cochrane Effective Practice and Organisation of Care Group undertakes systematic reviews of such interventions and have published 91 reviews. In an overview of reviews of the effectiveness and efficiency of guideline dissemination and implementation strategies to promote improved professional practice, Jeremy Grimshaw and colleagues demonstrated the percent improvement for a number of strategies, for example, educational meetings, guidelines and printed materials, reminders, audit and feedback, etc. As can be seen from the graph, all of these approaches demonstrate some improvement, but the evidence base is imperfect, with many small studies and methodological weaknesses. From the same overview of the previous slide, this graph demonstrates that increasing the number of strategies aimed at a particular evidence practice gap, for example, educational sessions and reminders and audit and feedback, did not result in increased effect. This finding suggests that a thoughtful approach to selecting strategies for implementing evidence, targeting identified barriers and based on theory to help explain mechanisms for change may be useful. Such an approach is outlined in a recent paper led by Simon French. Another source of evidence to guide implementation is the RX for Change out of Canada. RX for Change is a searchable database containing current research evidence about intervention strategies. A final example from the Cochrane Pregnancy and Childbirth Group, based in Adelaide, demonstrates this approach to understanding practice, developing an implementation intervention targeting identified barriers. This Cochrane review demonstrated magnesium sulphate for women at risk of preterm birth was effective in reducing deaths and cerebral palsy. The review went on to underpin the development of a national clinical practice guideline. The WISH project has successfully implemented this guideline through conduct of qualitative research to determine the barriers and enablers to uptake within hospitals, and developed and rolled out a number of targeted dissemination and implementation strategies to bring about practice change and widespread implementation of an effective research-based intervention. So to finish, my key messages: translating research into practice remains a major challenge. Translation efforts should focus on research synthesis. Skilled dissemination of research to a range of stakeholders in formats appropriate to the target audience is needed, and a systematic research-based approach is required for the development and evaluation of implementation interventions. Thank you.
I'd like to now introduce Professor Russell Gruen, who is a Professor of Surgery and NHMRC Practitioner Fellow and the Director of the National Trauma Research Institute. And Russell is going to talk to us about knowledge translation in trauma care. When I asked him about his key passion, he said that the most important thing is enabling others to improve their health outcomes through quality and continuous quality improvement. So we look forward to your talk.
Thanks, Helena, and thank you for the opportunity to present on this landmark occasion to you, my colleagues, peers and mentors. I'm going to talk about my own experience in trauma care and as a clinician researcher and make some reflections. I'm going to build on the excellent presentations of Professors Green, and it'll be lost on not many of you, I imagine, that Gruen is green in German. I'm going to build on those and not repeat what they've said, but hopefully highlight some of the key issues in knowledge translation from a clinician researcher's perspective. I'm going to do it in the topic of trauma care. It is a major international problem, responsible for 6 million deaths, 100 million hospitalisations a year, 12% of the global burden of disease. Road traffic fatalities will overtake most of the communicable diseases by the year 2030 to be the third leading cause of disability and fifth leading cause of death. In Australia, it's already responsible for 1 in 14 deaths, second only to cardiovascular disease for hospital-related expenditure, and the healthcare costs of $3.4 billion per year are over 7% of the total health expenditure, and due to the large amount of disability that results, it's an estimated $18 billion in societal and loss of productivity. I think we tend to wear our hats as clinicians and researchers separately. As a researcher, we're targeting the development and finding of new discoveries and new knowledge. As a clinician, we're usually focused on the patient in front of us and delivering the best care. And dare I say it, that is usually done without a great deal of thought about the research evidence that underpins each of the myriad decisions we make in any particular encounter. The field of knowledge translation links the two. And I think clinician researchers are ideally positioned with the right support to be able to grapple with the complexities of the union between discovery and clinical practice. I think it does, however, raise two specific challenges for us. The first is keeping up with knowledge advances, and the second is how to be effective, how to be an advocate, how to be a participant, how to be a supporter amongst colleagues of behaviour changing initiatives to match the knowledge of what we need to do. The organisation that I'm fortunate to be director of, the National Trauma Research Institute, embraces these challenges and knowledge translation research as core business. We aim to improve care of the injured through discovery research, discovering more effective treatments, through quality improvement to support high quality care, and through broad system engagement to improve trauma systems. At the heart of the Institute's knowledge translation activities, in partnership with Sally Green and the Australasian Cochrane Centre, is the Neurotrauma Evidence Translation Program, a $4.4 million 5-year research program sponsored by the Transport Accident Commission in Victoria to improve outcomes for people with traumatic brain injury through creation of a network of neurotrauma clinicians and researchers with expertise in knowledge translation and evidence-based practice, and to contribute to the field of knowledge translation research. The program is very similar, in fact, derived the rainbow, and there are 4 major themes that make it up. In the purple rainbow fields, the evidence resources. The program engages the production of systematic reviews, agreement on standards amongst professionals, and the development of locally relevant guidelines for practice. The second theme is about understanding how current practice relates to these evidence resources and standards through data interrogation, practice surveys, and interviews and ethnographic research. The third theme is about starting to think about changing practice for where there are evidence practice gaps. We have a team involved in theory-based development of interventions and intervention studies, including cluster randomised trials for behaviour change strategies and testing their effectiveness. And finally, as Sally mentioned, the capacity building component is not an afterthought. It's a central core activity to the program in which we engage clinicians and researchers in training, fellowship programs, networks and collaborative activities. I'm going to address the second of my 2 challenges first that I see for clinician researchers. This is about changing behaviour to match what we know. We do know we have to do this. Sally pointed to the recent MJA study of Australian healthcare more generally. It's replicated in almost every field specifically. Perhaps the biggest preventable death study in the world was conducted here in Victoria during the 90s, in which every road traffic fatality for several years was examined looking for errors in care that led to death of the patient. And 5% were deemed to be preventable, 27% potentially preventable. Mark Fitzgerald, who's Director of Trauma at the Alfred, and I think he's here in the audience today, undertook video analysis of 1,171 trauma resuscitations in the trauma bays at the Alfred, where there was a critical decision being made once every 72 seconds, 25 of them per patient. And of the 29,000 videotaped decisions, almost 10% were found to be erroneous. In North America, one of the largest trauma centres this year published its own experience, showing that fewer than 1 in 5 patients received standard guideline-based recommendations for the management of brain injury. And that in fact it was the sicker patients, the ones that needed it more, who were less likely to get guideline-based care. Mark Fall modelled the implications of these lapses in traumatic brain injury in 2007 using Brain Trauma Foundation guidelines, widely accessible and accepted guidelines for practice, and came to the conclusions that if all American patients with head injury just received guideline-based care, patients with good outcomes would rise from 35% to 66%, those with poor would fall from 34% to 19%, 3,607 lives would be saved, $262 million in healthcare costs would be saved, and $4 billion in societal costs would be saved. These are not trivial tasks. Clearly, data and measurement is fundamental to effective knowledge translation. In fact, it's data that relates what are agreed standards of care and current practice. And we've just demonstrated these as sliders with one of my colleagues, Peter Bragg, who's leading a program here. He's a musician and he spends a lot of time on the mixing desk. But I use this to introduce what I think is really a spectacular development. It's the union of 26 major trauma centres around Australia and 4 state-based registries to develop a nationally organised and coordinated program of trauma quality improvement. It's been funded by Alfred Health and the National Critical Care and Trauma Response Centre in Darwin to almost $1 million over 2 years to get this up and running. At the heart of it is data collection, sharing of trauma registry-based data that enables comparison between centres of performance. It builds on the traditional model of quality improvement with data collection, feedback and best practices with the ability for external benchmarking. That is analyses of each organisation and particularly those who are known to be best in the class. What do they do differently and how can you compare your centre to those centres? It's not necessarily public reporting. In fact, what's anticipated through the AUSQUIP program is very much not public reporting, but it is the opportunity to learn from those who are at the leading edge and to complement existing activities. The sorts of data output we can get shown here with the mortality observed over expected ratios for non-cardiac surgery in American Veterans Affairs hospitals. The observed over expected ratio is on the y-axis. Each hospital is lined up in order along the x-axis. These caterpillar charts show the superior performers are those who have a lower observed over expected ratio of mortality. There are those who are underperforming at the right end of the spectrum. You can anonymously show where an organisation sits relative to all of their peers. You can also study what the high-performing centres are doing and learn from them to be passed on to the lower centres. The experience in the US with these programs over the last 8 years has been dramatic. Overall mortality for non-cardiac surgery has fallen from 3.16% to 1.7%. Morbidity is down. All of the centres improve, not just the high and low performing ones, all of them. But the low performers are those that improve most. We aim to replicate this through the Australian systems and through the generous support of the National Critical Care and Trauma Response Centre and Alfred Health. So, understanding what good centres do well, what poor centres do poorly, and what the things are that shape the way people do their business is also crucial to knowledge translation and to the development of effective strategies for change. How do you pick what the key performance indicators are? Well, this is where it should really be based on knowledge. There is an international project underway, of which Australia has had several representatives, including Peter Cameron in this picture, to develop a core set of international indicators by which we can compare performance of trauma centres around the world. It's being led by the rather baby-faced young Doogie Howser of trauma care, Tom Stelfox, who's pictured in the middle of this picture, who's a critical care doctor from Calgary in Canada. And this is a very important movement that is going to allow us to get international benchmarking undertaken. These are crucial for a strategy of action. You need to understand the standards of care, the current practice, what the drivers of behaviour are, and only with those in hand can you develop an effective strategy for action. And that really is the core of the rainbow, as Sally has described it. We have built a structured dialogue process called the NTRI Forum, based on the McMaster Forum for Health Affairs in Hamilton, Ontario, and led by John Lavis, to facilitate development of effective strategies for change. The forum enables structured dialogue by key stakeholders to come together, appraise the evidence, collectively problem solve, and develop strategies to overcome the barriers to evidence-based practice. We've run 2 fora so far this year. We have another 15 planned, again funded by the Transport Accident Commission over the next 3 years. And it's a very exciting process. It's one that is very stimulating for the participants who come together with a joint goal of problem solving. I now come back briefly to challenge 1. What is the standard and how do we keep up with knowledge? Sally mentioned the importance of translating bodies of knowledge, not just individual studies. Systematic reviews, therefore, are the currency which we should be translating. But the systematic review enterprise is complex, it's time-consuming, and it is expensive. This is just one representation of the many stages of undertaking a systematic review. The key challenges to systematic reviews as the unit of knowledge is a deluge of biomedical research, the inefficient business processes. Many systematic reviews are still done on bits of paper or Excel spreadsheets. The duplication of effort with systematic reviews being done, the same reviews being done around the world, and often poor engagement of end users. The average Cochrane systematic review takes 2 years to complete. 25% are inaccurate within 2 years of publication, but less than a third are updated within this time. There is a fundamental problem if we're basing our current knowledge of what we should be doing on systematic reviews if the high quality ones are so out of date and potentially vulnerable. The Institute of Medicine has acknowledged this problem. Systematic review standards set a high bar that will be difficult to achieve for many systematic reviews, yet the evidence and experience are not reassuring that it's safe to cut corners if resources are limited. So if we can't do systematic reviews and we're relying on quick and dirty narrative reviews, we are likely to make mistakes. There is inevitably, therefore, a trade-off between the currency of reviews and the quality of them. High-quality reviews simply take longer. Julian Elliott and I published a vision for living systematic reviews in The Lancet 5 years ago that were comprehensive and authoritative reviews, updated by international networks and accessible as living evidence-based resources. The key steps in a living review are having methods of collaboration and statistical methods for the frequent updating, technology to help the process, and a community of participants engaged as curators of knowledge in their areas of expertise. We've been fortunate to have a Victorian government grant to develop some of the technological resources that help support the process. Sally's already shown the interface for a repository of systematic reviews that we're jointly using that now is a major database for relevant reviews. And we have engaged the key neurotrauma evidence curators around the world in a living review process that is just starting now. The World Health Organization has just created a global alliance on trauma care and for care of the injured, in which there's an evidence and research group that I chair, and we're in a great position to now be able to carry this work on through a connection of a network of interested people and knowledge curators and clinician researchers throughout the world. So in summary, clinician researchers have key roles in knowledge translation through their own knowledge of research, practice and policy, and by traversing the different communities. But we face major challenges in keeping up with current knowledge and supporting behaviour change. I think the initiative of an NHMRC Research Translation faculty actually is an excellent opportunity to position us well to foster excellence through knowledge communities, and I look forward to further discussions about this. Thanks.
Thanks, Russell. Next, I'd like to invite Professor Nikki Ellis. Nikki has had an illustrious and long career where she spent 10 years in academia, 10 years in government, which either means she needs help or is incredibly patient, and also 10 years in the private sector. So she brings that wealth of cross-sector experience to her current role, which is the CEO of the Institute for Safety, Compensation and Recovery Research. And Nikki's going to give us some exemplars and talk about end-user engagement. Thank you.
Thank you very much, Helene. And as Helene explained, I really want to tell you what I've been passionate about for the last 3 years, which is to make this interesting experiment work. And it's been an experiment. We've had to try and work things out as we go. And there are 4 centres, at least, here today that have been academic partners to us. And I just wanted to mention them. There are 4 that we work with particularly closely. MONCO, the Monash Centre for Occupational and Environmental Health. MIRI, the Monash Injury Research Institute, NTRI, Russell, you've just heard, and the Spinal Research Institute over at the Austin. And they've shown great forbearance as we've experimented to try and find better ways of closing the gap between research and policy. I want to start with a quote from one of my heroes, Peter Shergold, who used to be a very senior public servant at the Commonwealth, ended up at the top of Prime Ministers and Cabinet. And I think that this quote from him shows that the environment is changing and there really is an appetite for evidence-based policy. Was evidenced yesterday. I went up to the Institute of Public Administration of Australia, who wanted to hear about what we were doing, because on the government side there is a great deal of interest of how can they work with the academic community better. I like this one as well, which is out of the field that Sally and Russell work in, which is for evidence-informed practice. We need more practice-informed evidence. In other words, the only way it's going to work is if the research community starts to work with the stakeholders, the end users, much more in every stage of their research. And that's really the model that we've been working on. This is James Mackenzie. Anybody who reads the business pages would know that he's now become a real business leader. He used to be the chair of WorkSafe, who's one of our partners, and was the first chair of ISCA. And he made these off-the-cuff comments once, which I captured and put into our annual report, about how he saw the vision of the institute that I'm now the CEO of. And you can see that he describes it in terms of innovation. So if the industry partners wanted to continue to innovate and to change, then they really wanted to have access to evidence, and also saw it in terms of learning organisations and the fact that Victoria sees itself as a knowledge economy, a learning economy. So that's the way that that was the thinking behind us. The more pragmatic way of thinking about it is our three partners, WorkSafe Victoria, the Transport Accident Commission and Monash University. The two schemes really wanted to have research that was different. They wanted research that was relevant to their work, that they wanted research that was timely, so they've given us a timeline of they want research that will have impact on them in 3 to 5 years, so it's very applied, and they want research that they can use. They want to know that if the research is being done, it's going to be beneficial to them or to their clients. Monash has been a very active partner. They've put money in and they've also put a lot of in-kind in, and really where they're coming from is they seek to be a university that does research that makes a difference and recognise that it's going to need new ways of working, new business models. So they wanted to have the opportunity to attempt to develop a new model for a collaborative research process. So this is the model that we developed and use, and so you can see that in the loop at the top, we invest significant amounts of time and effort and money into setting the research agenda and translating the research, as well as doing the best research that we can. And in doing so, we work with our partners and with their stakeholders at every step of the way, and engage in a lot of communications. And we're a virtual institute, so we also need to build our partnerships to get the work done. I think that one of the big lessons that we've learned, and it became apparent very quickly, was the good oil is in getting the research agenda right and getting the research questions right. So that's where you need to put a lot of effort in, and if you don't get that right, there's no point. I mean, that's just absolutely critical. So I think that that's something that is quite different in terms of the way most research organisations work. One of the other things that we're learning about, and we're still trying to get this right at the moment, everything we do we're trying to get this right at the moment, but we're starting to make some progress, is that what we do is neither contract research nor investigator-driven research. So we encourage the academic partners that work with us. We have to find people that want to work on the issues that our industry partners want addressed, and we're increasingly realising that the kind of research that needs to be done is different. It's different design to the way that the researchers traditionally have worked. And with regard to the policymakers, we're having to make it plain to them that this is not contract research. If they just want to get something done very quickly that relates to a research question that they've absolutely determined, it may well be better for them to get consultants to do this. We're really at the point now where we're encouraging them to let go, to let the academic people that are working with us to come in, to recognise that if they truly want to become innovators, then they need to have some other ideas coming into their mix, because the policymakers will tend to have very short-term views. They've got piles of problems about to fall on top of them. They're the things that they want done. And so we're starting to see the value in having some longer-term conversations as well, and as the trust builds and as the academics that we're working with start to learn their business and can make ideas that are more relevant, we're starting to see the richness of the dialogue, the richness of the partnership. We developed a research to action model, a model for our translation after doing a literature review, so this is an evidence-based model. We're working on a kind of two communities approach at the moment, but I think that's going to change in the future. So you can see that we have an academic side of the model and a policy side of the model, and the two wheels are the research cycle and the policy cycle. So for us, the academic partner, as I've alluded to in the first contract, was Monash, and Monash was our preferred provider. We've now got a second contract, so our first contract was 25 million, and our second contract is for another 25 million to do some work on a specific program. Monash was a preferred provider in our first contract, but in our second contract we're now broadening that out to other universities as well. And you can see the yellow strip are the points at which we seek to bring the policy makers and their stakeholders into the research process. So the first one is setting the research agenda, which is a very broad process which involves lots of people. The second one is actually setting the research questions within the research framework. The third one is when we're doing the research, so we have ongoing engagement with sponsors of research. The fourth one is when the time comes to translation. We're also evaluating the impact that we have on the two organisations, and the last one is really about the development of a new model where we think we need to come even closer together. So we'll probably be embedding the research process into the policy process and vice versa to a greater extent. So collaborative research setting, this is the process where we think there's real value in bringing all sorts of people together at a very early stage to set some high-level ideas about what the research needs are. So, for example, when we were doing our first strategy, we used a futures approach, so we used future studies methodologies. We brought about 100 people together and said, what do we think this sector is going to look like in 2035? And then if they're the scenarios, which are the ones we want to go for, which are the ones we want to avoid? And if that's the case, what are the knowledge needs that exist in order to be able to avoid the futures we don't want and get to the futures that we do want? And we used a combination of horizon scanning, so evidence synthesis. We used data mining for some of that in innovative ways, working with our Department of IT, and we used online discussions, and then we moved into a futures workshop. We've just kicked off a new program of research which is going to be developing new models of care for people with catastrophic injuries, and it's care in the home, so it's community-based care. So we brought all sorts of parties together. We had architects, we had assistive technology experts, we had people with disabilities, organisations representing people with disabilities, policymakers in disabilities, and so on, to start to talk about what the ideas were, what the needs were. We then, as I mentioned before, continue to have discussions around the research questions. One of the lessons that we learnt was that we needed to reorganise our research into streams that made sense to people. So in the early days we hadn't done that, and we had numbers of projects and people couldn't get visibilities on what we were doing. So we reorganised our strategy, reorganised our programs into themes that that made sense to the academics who were working with us and made sense to mid-level in the organisations that we were working with. And once we did that, things really started to fall into place because people had much more visibility and could understand what we were trying to do. A second part of that is to then establish a very participative research governance. We've changed this quite a bit over time, learnt a bit along the way, and we have program advisory groups now around each program where key academics and key policymakers, the main function of these groups is to develop the research program, so to consider the research questions. We also have other participative research governance mechanisms. This is a slide of our neurotrauma research program governance mechanism, and the main thing I want to convey to you is complexity. This isn't simple, and one of the things we're starting to find is we need to engage with existing mechanisms all over the place, not just build our own. So these things take time and can be quite complicated. Just to remind you, I've been talking about setting the research agenda, and I'll quickly move through the other two areas. In terms of facilitating the research, one of the major things that we've learnt and are really starting to think more closely about now is the different design of research that's required for this kind of work. We need to have a balanced portfolio of research. We need to be able to say we're doing this now and this is where it's going, this is what the benefits will be at the end. And there's much greater emphasis on evidence synthesis, there's much greater emphasis on interventional research and much greater emphasis on implementation research. It's also iterative, using realist evaluation theory and increasingly putting teams of researchers alongside innovation, alongside new policy development, and making evidence available to inform innovation and then assisting with iterative evaluation along the way. With regard to translation, we are getting to our production line is such, we've been going for 3 years, we're starting to really focus on improving our translation mechanisms now, but our program advisory groups really help with translation, so there's lots of discussion about how to achieve this. We're focusing on the way we present the reports, so we're using the 25-page format and refining that all the time. We do a lot of presentations, one-on-ones. We're fortunate in that we can get to the policymakers, so we take the research findings and have conversations with the policymakers along the way and as the research is coming out. But we also recognise that increasingly in the future there'll be further research required on implementation to develop tools and once to have well, there's likely to be additional implementation research on some of our early work that's now coming to fruition. We think we're required to measure our impact, and this obligation has really forced us to come to terms with this, because most of you would know this is something that the academic sector has been looking at for a while, not, I think, getting too far with it. We're quite fortunate in that we've got a closed system. We've got 2 schemes, so it's quite a large population that we cover, quite large organisations, but not too large. We interface with the health system, but we're a little bit separate from it, so we're a nice little petri dish in some ways. So we developed this impact assessment framework. We started off with the best thinking that had come out of the academic sector. We were fortunate to have one of the consultants who had worked on that for the Commonwealth, and then we engaged with the actuaries on the schemes that we work with to assist us further. We now have this framework embedded in our project management system. So basically it means we don't stop at research output, we keep going and track adoption, and then we measure impact. And we do this in a couple of ways. One is on every project we fairly opportunistically take every occasion that we can to collect information on adoption and impact, and then have a more formal follow-up in 12 months. But then we also do detailed case studies through our return on investment project, and we've just finished our first round of those where we did 9 case studies of our projects. So this is our research pipeline. These are the numbers, and you can see that we're able to demonstrate we had adoption in 27 projects and impact in 17. We have been able to analyse the types of adoption, which I won't go into now, though that's very interesting, and we're able to describe the types of impacts that we have in our projects. Our return on investment, this is one project that we had which Monco did for us, and we were able to show that we had a return of 5-fold return on investment in this project. So my conclusion, so I don't want you to feel obliged to walk out at an offensive sexist slide. This is irony, and I wanted to conclude with what I've learnt personally over the past 3 years that I thought might be valuable to you as researchers. If I wanted to say anything based on my 3 years' experience, what would it be? So one, I think establishing and managing successful industry partnerships is hard work, and I think it requires more investment than people realise in research development, in project management and research translation. So I think there's going to be the question of resources in moving towards new ways of working. I think that you need to take a long-term view, and you need to build trust and respect with the people that you want to work with, the industries that you want to work with, and learn their business so the quality of your offerings increase. I think that it's not really possible to the extent of the cultural clash between policy and research is just absolutely huge. So you need to understand the nature of the difficulty and be very patient and willing to work on problems. I think as well as building relationships directly, there's huge advantages in working through the industry stakeholders, the policymakers stakeholders as well. I think that jointly setting research questions and making sure that you've jointly determined mutual benefits is critical at the outset. Recognise it'll be different kinds of research, with interventional research and knowledge synthesis being very important. Plan and project manage well. Expectations in industry in terms of delivery on time and budget are somewhat different to ours, I think. Identify and tackle problems early, because they'll always come up, and recognise that a lot of mutual learning is needed. So seek feedback and listen as well as giving feedback. Thank you.
Now, our last speaker, I had the fortune of hearing her speak recently, and she was definitely the youngest amongst a very illustrious panel, but I think had the most inspiring story to tell. Dr. McIntosh is a pharmacist, and she had a PhD some years ago, but interestingly again spent 7 years outside the direct academic sector in a translation and commercialisation of discovery research role in the US. And perhaps it was that role, having worked in translation in this setting in a discovery translation of discovery research, that in fact led her to think perhaps very differently to the way she approached a project. Michelle has recently been awarded with an international award as developing an innovation that's most likely to be transformational in maternal and neonatal healthcare, and so we've asked her to come and share her story with you. Thank you.
Yes, thank you very much for the opportunity to speak today, and I did look at the list of speakers, and I didn't necessarily think I felt like the youngest, but I did feel like perhaps the least qualified. But thank you for the opportunity to tell you about a project that I've been working on now for probably, well, the last 4 or 5 years, and it's becoming an increasingly large priority in my research portfolio at Monash University. I joined Monash, or rejoined Monash after getting my PhD there about 6 years ago, with a focus on looking at developing drug delivery systems for the lungs in particular. And as we were doing that, we came up with a number of examples that we thought would be worth looking at a little bit further. And one of those examples was taking a hormone, oxytocin, which is used routinely in healthcare around the world. It's used to prevent and to treat postpartum hemorrhage. And that was where we started looking at this project, because there are a number of limitations associated with access to oxytocin in developing countries. And we thought that targeting delivery to the lungs would be one way to overcome that. And the idea of delivering drugs to the lungs is not new and it's not novel. And in the pharmaceutical world that I was sitting in, it wasn't that exciting. It was kind of cool, and we thought we could get some good papers out of it and a great way of training some PhD students. But it wasn't until I attended a conference that was hosted in part by the Bill and Melinda Gates Foundation, where they had put out a call for innovative technologies for delivering medicines and solutions for maternal and neonatal healthcare. And so I thought, oh, I'll go and I'll talk about this idea of inhaled oxytocin. And of course, people in the pharmaceutical world said, no, it's a bit boring. It's not that new. But actually, when I went to the conference to talk about it, it was kind of like, you can do that? And it just was an idea that hadn't really sort of crossed people's minds. And so I think what it highlights, which again is a message that's been coming through today, is that communication and bringing unlike minds and unlike experiences together is such an important way of identifying all of the key facets of how do we translate a medicine. So many of you will be familiar with the Millennium Development Goals that were first described in 2000 through the United Nations, where 189 countries agreed, or they promised, that they would find solutions to enable or to reduce poverty, reduce hunger and improve the situations for the world's poorest people in the developing countries. One of those Millennium Development Goals, MDG 5, is focused on improving maternal mortality. And that ambition is to reduce maternal mortality by 75% by 2015, and also to obtain universal access to contraceptives. Now, MDG 5 is one of the goals that we are making least progress on. Progress has been made and it's promising, but still today, every minute, a mother will die from pregnancy and childbirth associated complications. Most of those women will die due to severe postpartum hemorrhage within 1 to 2 hours after giving birth. And the tragedy of that statistic is it is almost completely preventable. The drug exists, it's safe, it's effective, it's oxytocin. We use it in Australia many, many times every day. But in these developing countries, the biggest barrier, my biggest barrier might be going on to the next slide, is obtaining access to these uterotonic agents such as oxytocin. And so the policies are within those countries, the WHO recommendations, we follow those. Every woman will receive access to oxytocin after childbirth, but it is very much easier said than done, like changing slides. Okay, so just to describe some of the limitations with obtaining access to oxytocin, it requires cold chain storage, it requires refrigeration, or else the drug degrades and it loses its efficacy. It must be administered via a needle and syringe as an intramuscular or intravenous infusion by a trained healthcare provider. Yet most of the women in developing countries give birth at home and often alone. The quality of the products is a problem. There are a lot of counterfeit products on the market. And if it's not stored correctly, then the quality has deteriorated. And when those drugs are available, they're often used for purposes other than what they were intended, which was prevention of postpartum hemorrhage. So our research hypothesis was that we could develop an inhaled form of oxytocin. We could engineer particles, dry powder particles containing oxytocin that would not require cold chain storage and that could be inhaled by the patient, where it would be absorbed from the lung and reach the systemic circulation to exert the effect on the smooth muscles of the uterus and therefore reduce, prevent and treat postpartum hemorrhage. We wanted something that could be easy to administer, was needle-free because there are a lot of complications associated with administration. There is another drug that's recently been approved for this purpose, oral misoprostol, which can also be used in home birth settings, but it's not as, well, there's literature suggesting it's not as effective as oxytocin, it's not as stable as we'd like it to be, and it's also not available in some countries because it can be used for termination of pregnancy, and in many instances that'll prevent it ever being available to women, even for postpartum hemorrhage treatment. And so we think our inhaled oxytocin concept would overcome a lot of difficulties. But we're very much aware that women in developing countries where we're targeting this from, they're not familiar with inhaled medication. And so how are they going to accept this idea of inhaler? Is it going to be intuitive, and how do they use it? Are there preferences for whether this medication is orally inhaled into the lungs or inhaled into the nasal cavity, because it could be absorbed? There's no real biopharmaceutical reason why it couldn't be one route of administration over the other. And so I think that's why Helena's asked me to talk to you today, to talk about what are the processes that we've been following in order to try and really understand the end user and let that guide our development of a product. We know that we can develop a stable formulation. We know that it can be absorbed from the lungs, but if we don't have a product that a woman wants to use and is able to use, it will have no impact. And so we must understand the end user for us to do that. So the first stage of our project, and I'll briefly take you through some of this, is our preclinical evaluation. We've done the stability studies and we can show that we get good long-term stability at 50 degrees Celsius, which is well above ICH conditions. We've also got some preclinical pharmacokinetic evaluation. We've done this study in what we think is a physiologically relevant animal model, which is sheep. We can see here that the blue profile is after we've given an intramuscular dose of oxytocin to sheep, and we can see the plasma concentration profile versus time. And then the red dots indicate the plasma concentrations after we intratracheally administer a dose of our dry powder into the sheep. So it's not a full representation of the clinical situation, but it's enough for proof of concept, and it's enough for us to be confident that if the drug gets into the lung, it can and it will be absorbed and can therefore go on and have an effect. So we also had a pharmacodynamic model where we used sheep, postpartum sheep, within the 24-hour period immediately after lambing. We had connected electrodes, EMG electrodes, to the uterus of the sheep so that we could monitor smooth muscle contractility. The profile here on the left is the basal activity of smooth muscle in the postpartum sheep. So these sheep are not experiencing postpartum hemorrhage. They do not have an atonic uterus, which is often the cause of PPH in women. So it's not a full therapeutic model, but we have these basal baseline contractility in the smooth muscle. And on the profile on the right, we can see that within a minute or so after administering oxytocin into the lungs of our postpartum sheep, we see a very rapid and significant increase in smooth muscle contractility, which again was further confidence for us that we should take this project to the next step and look at being able to scale up and move towards the clinic. So what we've just been working through recently, and I just came back from a week in India, I think 2 weeks ago now, where we set out with the objectives to engage with the local stakeholders, the end users, the policymakers, the clinicians, and try and understand what were their thoughts and views on the idea of an inhaled oxytocin product. How is oxytocin currently used in practice? We know what the guidelines are, but how often and how closely are they being followed at the various levels of the healthcare system, primary, secondary and tertiary levels? To what extent is the active management of the third stage of labour implemented? And so administration of oxytocin in the third stage of labour is known to prevent the incidences of postpartum hemorrhage. Is an inhaled drug delivery product culturally acceptable? What are the implications to an inhaled product? Is there a preference for nasal or oral? What about the device intuitiveness? And is it safe? Is it likely to be used as per the directions? And we recognise going into this that actually the biggest challenge that we face is not the pharmaceutical science, but it's the education, the implementation and the translation. So we took with us a number of devices. We were speaking to vendors who manufacture devices that are all low cost, what we see as simple to use and might be suitable for emerging market application. And we took those with us when we went out and talked to some of the stakeholders. And so we went to a small village in northern India, Shivgar, a population of about 1,000 people, and we sat down with the aid of some interpreters and translators to ask them about their experiences in pregnancy, and did they give birth at home, and what stopped them from, there was a clinic not far away, why didn't they choose to go to the clinic, who was with them when they gave birth, would they feel comfortable self-medicating with something that normally is only available from the doctors. And so we spent the afternoon talking with mothers and grandmothers and mother-in-laws and some of the children as well. And the feedback that we got, which I'll summarise shortly, is just going to be absolutely critical to the path that we take moving forward. But we won't only go through this process in India. We've got plans for getting similar information in sub-Saharan Africa within the next few months. And also it's a huge problem for some of our nearest neighbours in Indonesia and Papua New Guinea that have some of the highest maternal mortality rates in the world. So when we were visiting the different healthcare facilities within the system, we see that the first point of call is someone who's referred to as an ASHA, an accredited social health activist. And her role is to incentivise, to try and encourage the women to go to a facility, because ideally that's the best place. That would be the safest place to give birth. But culturally and traditionally, that's not where these women give birth. They would rather give birth at home because that's what their mother did and her mother before that. And so quite often we found that the Aishas, in fact, would be present at the birth. They would supervise the birth, and then they would communicate that birth to the nearest primary care facility and fill in the paperwork, and she'd still get her incentive, and so would the mother. But still, it was some contact with someone who'd had some level of training. Then we talked to auxiliary nurse midwives, and did they have oxytocin present, or did they have access to cold chain storage? And sometimes yes, but most of the time no. Primary care facilities, the next point of care, maybe there was oxytocin, maybe it was refrigerated, but not in all places. And then in fact I talked to the head physician in one primary facility and sort of asked, what's your usage of oxytocin? He said, I don't do that. Don't do uterine massage. I tell people not to bother. But the evidence is out there to say that it can save lives. But that was her preference, and that was what was happening. Into the community healthcare centre, again, variable levels of care. And the longer we were in India, the more we realised the size of the challenge ahead of us. But the longer we were in India, the more our determination and passion to be able to see this happen grew. When we got to the tertiary care facility, there was another interesting dichotomy, in that the head of the facility said 50% of the births are booked into the hospital, and the rate of PPH, postpartum hemorrhage, in that group is very low, almost nil. The other 50% of the childbirths that occur in the hospital are the emergency births that occur, somebody arrives after referral from elsewhere where they're already bleeding. And by the time they get to the tertiary care facility and they're triaged, they've often lost so much blood that it's too late. And so the maternal mortality rates in the tertiary care facilities are higher than at the other facilities that make their metrics look not so good. Why are your patients dying? Well, because the time they get them, they're extremely unwell. So these arrows represent the point in time where women are dying. Not at their first contact or their second contact with the healthcare facility, but on transit to their second point of referral or their third point of referral. And so, again, we're looking at finding a solution where if we can give access to oxytocin earlier on, we might be able to at least initiate some sort of healthcare support for them before they've lost so much blood that it's then too late to save their lives. We were investigating cold chain storage, so we went to the local drug peddler to say, can we buy some oxytocin? You need a prescription. I said, I haven't got one. Oh, okay, we'll give it to you anyway, thank you. I was very concerned when I arrived back in Australia and they were filming border security. Anyway, we did buy some ampules, and we're analysing the content of oxytocin in those ampules today because he took them off the shelf. There was no cold chain storage. It was 35 degrees and 90% humidity. And so we suspect that the content of that oxytocin is much lower. Again, this was a photo from a hospital, no cold chain storage. They see over 600 women deliver every month, and there's no oxytocin available in the hospital. Oxytocin's even harder to access, we found out, in India because the government has restricted access and availability to oxytocin because it's been used in the dairy industry to increase milk production. And I know they're not dairy cows, but they were the only photo I had. But strangely enough, the things you learn when you go out and talk to people, oxytocin's also being used to increase the size of vegetables. And so they're injecting pumpkins. And so it's harder for women who need oxytocin during childbirth to get it because it's been restricted to stop its inappropriate use in increasing the size of vegetables. So to summarise quickly, what were our main findings? When we spoke to the women in the community and the traditional healers, referred to as quacks in the local area, here's a medication in an inhaler that'll stop bleeding. But you can't stop bleeding. You have to remove 9 months' worth of pollution that have built up in these women. So if we go out with a product to stop bleeding, nobody's going to use it because that's contradictory to their belief. And we don't want to come in with a product and sort of dish out on their beliefs and sort of say, well, that's not true, of course there's not pollution. We want to come in and be accepting and understanding and find a way that we can introduce something that runs in parallel and supports those traditional beliefs. We said, have you ever experienced or come across women who die from bleeding after pregnancy? No, nobody dies from bleeding after pregnancy. They do die from weakness though. So there isn't a link that the women who are weak have lost blood and they're anemic on top of that. The idea of inhalation as a product was very well received, which was a relief to us, but we weren't sure. We had no idea whether that would be well received or not. But the feedback at every point of our discussions was that orally inhaled products was acceptable. It was associated, they used steam inhalations, menthol inhalations for colds, much like we might, and it was seen as a cleansing process, whereas intranasal was viewed more as something for mind-altering substances, and if you breathe it into your nose, it's very close to your brain, and they wouldn't like that. And so we've already answered one of those questions to save us going down the path of developing an intranasal product, at least in India, in this area, intranasal isn't a viable option. We also saw in the healthcare setting at the tertiary level that the senior clinicians were sort of like, you can't really give a product for people for self-administration because those people can't really help themselves. They didn't give them any credit for their intelligence or capability as individuals who just want to survive. And yet when we talked to those individuals in the villages, we knew they were incredibly intelligent and capable people who, if given the opportunity, given the training and given access to the resource, will be able to make decisions to improve their health outcare. So anyway, I'll wrap that up at this point in time, and just to acknowledge that the funding we have received to this point in time has been from the Bill and Melinda Gates Foundation and also through a partnership of funding agencies here through a program called Saving Lives at Birth. Thank you very much.